I think to echo the sentiments of Montgomery County and Dayton Public Health and what Sarah talked about is with these community health assessments, we have the ability to maybe coordinate and collaborate with those assessments and making sure we have implementation plans that make sense for the region, that are measurable, that we're measuring the right things, and that we're focused in on outcomes. The great thing that we have in this community now is we have very rich data, both at the county level but also on the regional level. For the first time ever, all 28 of our hospitals utilize the same community health assessment form. So 12 county area, 28 hospitals, all utilizing the same nomenclature, the same data set, so we can kind of have a good baseline on how we move forward. But then how do we use that data? And I think sometimes we trap ourselves into looking at traditional ways of utilizing that data, and we're really looking at ways to maybe try to look at the data in different ways. So for example, there's a specific zip code that we have in Montgomery County that we have the largest amount of hospitalizations because of diabetes from that one particular zip code. And in that zip code, we had 122 patients that were responsible for 689 patient days in our hospital because of diabetes in that one zip code. That zip code does not have any grocery stores in that zip code, and no grocery stores in the surrounding zip codes. But it has 32 mini-marts in that same area. $8.4 million costs to the healthcare system because 91% of those are either on Medicaid or uninsured. So, you know, our hospitals are looking at, are there innovative ways that you can look at that data to affect that? Could you do farmers markets twice a week and incorporate wellness care and health professionals and caseworkers into that zip code, making sure they're getting vegetables, nutritional advice, hooking them up with an FQHC or a medical home so we're not treating the symptoms of the disease in our hospital, and we can cut down the 689 patient days from those 122 patients. So we have a lot more data than we had just 5 years ago, and we get the hospital, we get the data on a hospital level, on a county level, and on a regional level. And the last point I think is important is that we should not, I know we're focused in on Montgomery County, but we also need to be focused in on our surrounding counties because that impacts the health and the safety and the wellness in our community. And I know, our law enforcement can talk about other individuals coming into our community from outside regions and how that impacts us. It impacts the healthcare system. So there's a benefit to look outside of Montgomery County also. But I think we have a rich set of data, and we need to look at kind of non-intuitive ways of utilizing that data to provide healthcare in maybe non-traditional settings than we've had in the past.
Thanks, Brian.
I reserve the balance of my time.
Okay. I think it was 3 seconds you have in reserve.
Big balance.
Make good use of that.
Yeah, we'll give you that going forward, Brian. Okay, we're going to be shifting a little bit here. The health folks can take a little bit of a breath here for a question or two, except really for Shalyn and Andrea. But this is going to be more of a law enforcement type question, but we want to hear from Shalyn and Andrea first, and then we'll hear from Major Johns and Sheriff Plummer. Question number 4 is, what are the most effective ways to integrate the criminal justice, mental health, and substance use systems? Shalyn?
Okay. I think the Major mentioned a program, the SERVE program.
Yes, ma'am.
Which is a phenomenal program. And I like that program because what it does is it works alongside ex-offenders that go back out into the community and begin to build relationships with the community and the police force. I love that concept. And I think that that is a model that if we were to really invest more into, that we would see a decline in crime. I really believe that because they're doing a phenomenal job. And I think also a lot of our, and I liked what Andrea said about the mental health piece. It's that we have to work more closely with our mental health agencies, because when you talk about drug addiction and crime, and it's really probably something that we never really think of, but it has some form of a mental illness concept to it. I mean, it really does. You know, because normal people don't do some of the things that I mean, you know, normal as normal can be. But a lot of normal people don't do the same things that people on drugs or doing criminal activities do. So I think that as we begin to work more closely with the mental health aspect of this thing and form those solid relationships, that we're going to see a greater impact in terms of the decline in criminal activity and as well as drug addiction. But I think that as we continue to look at ways to help our community, those collaborations are so important. I mean, collaborations that are able to say, you know I can't do everything, but with your help, we can make a difference. With your help, we can help to improve the lives of those that come to us looking for direct services. And there's a lot of them out there, a lot of people out there still struggling and looking for a means of getting better and making our community a better place to live. And we're all involved in this. It's just not one or two. We are all involved in this because we have to live in our community. And we want our community to be the very best that we can be. And that includes our police departments, our mental health agencies, our drug treatment agencies, and the community coming together, working together. And let me say this before I end my thing. One of the things that I was thinking about today, if we formulate a neighborhood to neighborhood collaboration where neighborhoods come together in unison working on the same problems, because every community is basically faced with the same problems. And so as we come together and build those relationships and talk openly with one another and not at one another, then we can also begin to create a safer and more livable community.
Thank you, Shailene. Andrew?
Well, I think the simplest way to put it is we need to stop putting ill people in jail, right? I mean, I talked a little bit earlier about how mental illnesses and substance use disorders are brain illnesses. And we need to acknowledge the research that has said that and really stop putting sick people in jails. But that's exactly what we've been doing, right? Right now we have 3 times more seriously mentally ill people in jails and prisons than we have in hospitals. Mm-hmm. That's a problem. And part of this happened with the deinstitutionalization that has happened in our country, where we saw, just a recent staff, in 1995 there was 1 psychiatric bed for every 300 Americans. In 2005 there was 1 psychiatric bed for every 3,000 Americans. So you see that basically we just replaced our mental institutions, our psychiatric hospitals, with our jails and prisons. So in saying that, I want to first acknowledge that, yes, absolutely, mental illnesses and substance use disorders, because it impacts the way individuals think and feel, which then ultimately impacts the way they behave, means that sometimes they behave in ways that bring them to the involvement of the criminal justice system. And so the answer is not to not acknowledge that, but what it really means is doing a better job at differentiating between those who have committed crimes who did so because they have a mental illness or substance use disorder, and those who have committed crime merely because they have criminal thinking. Those are 2 different populations, and they need to be treated in 2 different ways. It also means that we need to do a better job at integrating our criminal justice system and our mental health providers so that they work in tandem with one another. Now, easier said than done, this means expanding mental health courts and drug courts so that every single individual who has a mental illness or a substance use disorder that comes to the attention of the criminal justice system has access to a judicial system that understands mental illnesses and substance use disorders for what they are, as mental illnesses, and not as just criminal behavior, right? And then once we did that, one of the things that we need to do is also access, make sure that we expand access to multiple treatment modalities, right? We've got to get rid of the stigma that when we give someone with a substance use disorder a medication, that we are replacing one drug for another drug. The research does not support that. We are giving a medication to an ill person just like we would give insulin to a diabetic who hasn't controlled their condition through lifestyle choices, right? And so we need to get rid of that stigma and begin using life-saving medications and have all of those modalities available to individuals who are in the criminal justice system, but also have a mental illness.
Thanks, Andrea. Major Johns, how do we integrate?
Well, I agree with Ms. Coleman. I think it's all about partnership and communication. And probably the best way for me to answer this question is kind of share a story very, very shortly with Mr. Gross and I about a program we started recently called the CarePoint Needle Exchange Program here in the city of Dayton. So if you don't know, we have a needle exchange program now in the city of Dayton every Friday at Life Enrichment Center over in East Dayton. But I was asked to go to a meeting by the mayor at Public Health. I get there. I have no clue who Mr. Gross is. I don't know most folks in the room. But through talking and knowing each other and finding out what each party brings to the table, we actually got things done. And I got to say, in 23 years as a cop, it was probably the most easiest and fastest program that came from beginning to actually fruition in a short amount of time, because we had people in the room who were interested, who were driven, who can make decisions and make things happen. And that's what we did. So, I learned so much from that process from you, Mr. Gross, and from all those folks. It was just really refreshing from a cop standpoint to go to a meeting that actually things happen. We go so many times to meetings and we talk about other meetings and you leave there and nothing happens. But I think it's communication, working together, and and things like that. So now we have a needle exchange program that we didn't have before. You can get clean needles, which is only a small part of what we do there. We have folks there from recovery services to talk to those folks and send them in the right direction to get treatment for their opiate addiction. We have mental health folks coming there now, offering their services, HIV testing, birth control measures are there. So it's a great program. And it was only took place because we sat down, we worked hard and communicated and shared what we had together. So I'm done.
Just because you offered some compliments to the facilitator doesn't mean that you are
I don't
free
get
to
I
not
can't
answer any
skip
more
a
questions.
question or anything?
Yeah,
Golly.
we'll not skip
I do
you.
have a gun, though.
You're on the agenda. Sheriff Plummer?
Yeah, he's trying to leave early on us. I think our drug-free coalitions that we're all working on has been very helpful to our community. We're all sitting down and realizing we all have the same problems. And Andrea has resources we can use. We have resources they can use. And I think that's helped us all solve some problems. We've been tracking the top 13 offenders in our jail for the past 5 years. And 50% of them have mental health issues. And we've dropped the ball on the mental health problem in this community. It goes hand in hand with substance abuse issues. That small population has been arrested 708 times in the past 5 years. They've done, cost us over $500,000 in incarceration fees. They spent over 10,000 days in our jail. So if we can solve problems with a small group of people, we can save a lot of money. We can use this money wisely in other areas. We have to do a better job with data collection. I'm glad the hospitals are doing a good job with that, but the police departments are terrible with data and sharing data. I think we have 29 departments, I think, and probably 22 different data sets. So, the criminals, they don't know boundary lines. They come and go as they please, but we do a terrible job sharing data. So we need one good records management system that everybody in the county uses so we can share data, we can share reports, and we can target the right criminals in this community, because there's only a few people causing all the problems. And we're trying to identify them, but data from other communities would certainly help us out.
Thank you, Sheriff Plummer. The next question also is targeted to Andrea and Sheriff Plummer and Major Johns, and it's pretty straightforward. And it's a question I think that a lot of us have thought about for some time, and that is, what are the most effective community-based drug prevention strategies? Andrea?
Well, I wish this was an easy answer, but it's really not, right? If you go back to the social ecological model that I showed earlier, which showed that we have to have multifaceted strategies, that's what we're talking about. Up here on the slide, you see those strategies that have been approved by the federal government that are deemed specifically prevention strategies. And what the research shows is that a healthy community is well balanced across all of those strategies, so that none are left off the table and that there is a focus specifically on all of them. Everything from, information dissemination, making people aware of what those risk and protective factors are, what you can do to keep yourself healthy. If you are healthy, let's keep you healthy. What are those things? And truly, that's everything from radio spots to TV messages to billboards. But get that message out there, both about substance use and what people can do to stay healthy, but also about mental wellness. As you move to the right, you get into community-based process, which is really the act of pulling community stakeholders together for a common purpose. And I think our community does a really good job at that with the Sheriff's Coalition, with the Montgomery County Drug-Free Coalition, with the Montgomery County Prevention Coalition that Adamus is currently chairing. But it acts as that conduit to get people invested in being a part of the solution. And then you have problem ID and referral, and that really is just identifying folks who are in need of treatment, making sure that they get that access. There are alternatives, which every community should have, because it's all about making sure we have healthy, drug-free activities available for our citizens. Some of our neighborhoods do not have those. Sports clubs, recreation centers, churches that are doing healthy activities. Some communities don't have that. If you do those 4 activities and do nothing else, you will never see a change in your population health. The other 2, prevention, education, and environmental, are the 2 strategies that have been shown in isolation, if you do nothing else, to make a difference in people's lives. Prevention education is that 2-way dialogue, mostly where you teach a curriculum on life skills and decision making. You make changes at the individual level. And environmental, where you are changing standards and codes and laws that have an impact across a broad community. And so it's important that we do that. And then the very last thing, I just wanted to bring one specific program to everyone's attention, that if we did nothing else, this is the one that we really should be focusing on. The PACS Good Behavior Game is the prevention program that has the greatest return on investment of any prevention program to date. It's a program that teaches young children to self-regulate their behaviors. It's done directly in the classroom. It is specifically targeted for first graders because that's where their brain is developmentally ready to learn that self-regulation. When people implement PACS, teachers get more time to teach because there's less classroom behaviors. And you can see longitudinal studies that show the impact that it has on things like substance use, suicidal ideation, just really phenomenal stuff. If I had my magic wand, I would put this program in every first grade classroom in Montgomery County.
Thanks, Andrea. Sheriff Plummer?
We have to do a better job on prevention and education. We've lost all the DARE programs due to funding cuts. We've initiated a STARS program where I have one officer that goes into schools and tries to educate the youth on consequences and drug awareness. But you can't get in a school and talk to an individual one time. It has to be a long-term, sustaining situation, which we don't have, unfortunately. So somehow we have to get back into schools. And for law enforcement, getting in the schools helps out tremendously because it builds bonds with the students. Let them know we're not the bad guys. We're here to help you. We may show up at your house occasionally on a domestic and take somebody to jail that needs to go to jail, but we're actually here to help you. So if we can get funding to get back into the schools, which we're really working on, I think that would help out tremendously. In police community relations, the kids can trust us, and we can educate them on, drug awareness and all the problems out in our community.
Thank you, Sheriff. Major Jones?
Well, I'm just glad to hear about the PACS program from Andrea because, quite honestly, I think from a law enforcement perspective, we've kind of failed in regards to crime prevention in youth. The just say no and the DARE. I mean, if you look at the stats, it was never really overly effective in preventing drug use from kids. We've tried GREAT, which is like gang resistance education over at Ruskin School and Xenia Avenue. And while it's a good program to build that bond, there's not a lot of evidence there as far as it prevents drugs. And I thought back when I was a youth, and I didn't use drugs because of my family. I have cousins who have overdosed and died, but I knew my grandpa would be really disappointed if I used drugs, and that's why I didn't. But last year I went to an overdose where a mother had overdosed with her son and died. And the son died and mom lived. But I mean, that's the kind of things that you see, and how do you prevent that? But I mean, for my career, I've kind of found that folks use drugs pretty much for 3 reasons. One is social pressure, be it from a boyfriend or a friend, or you'll see in a school, a medical illness where they get pain pills and they get addicted and they can't get the prescriptions anymore and turn to heroin, which is so cheap and readily available. You can buy heroin for $5 on the streets of Dayton, and you can't touch a pill for $20 or so. And thirdly, they use drugs. There's an issue where they're having some emotional issue or mental health. I agree with Andrea that it ties into the mental health part of it, and there's something lacking in there, and they turn to drugs to kind of fill that void. And I think if we could get into schools, like Andrea said, the earlier the better at first grade, and instill it in them that drug use isn't, it isn't good, it isn't right to do. But we have young kids that go home from school every day, and their parents use heroin. So how we get over that hump, with poor households that set poor examples, I don't know. But I agree with Andrea that the earlier the better. The first grade, get in there when we're nice and young, and preach that the use of drugs is not the way to go, especially the use of like heroin, where it just takes one mistake. When I grew up, we smoked weed. All my friends and stuff did, and you smoke weed, you may get sick or really hungry. That was kind of a joke there, but but you use heroin just one time, and it takes that one time, your life is over, and we just can't have that.
You weren't trying to segue into obesity or anything like that?
No. That's the next panel, we'll get into
Yeah,
that.
we're not allowed to do that. That's against the rules here.
Okay, I'm sorry.
We haven't forgot about you, Dr. Payton. In fact, the next question, question number 6, you're the only responder here, so it's going to be your stage. We've touched on this already, though. But question number 6 is, if existing programs do not sufficiently address food access and nutrition in our community, what do we do about it?
Okay, so no surprise, I've got data. So the first thing I wanted to do, we have a problem in Montgomery County. This is some food insecurity data, 2013 or 14, it's 13. This is the most recent data. It just came out recently, and you can see we do have a problem. If you look at our children, 1 in 4 children in Montgomery County aren't sure where their meals are going to be coming from. If we have data like this, it's showing our kids, how are they going to flourish? How are they going to learn? How are they going to be healthy when they don't have the basics of food? So next slide. More data. So this is another slide, the map that we have here of Dayton. And these are the food deserts in Montgomery County. So those areas outlined by red, those are the areas that are considered a food desert. A food desert is an area of low income that a majority of the population are a mile or more from a supermarket. And you can see here we have overlaid some different spots on, or different things on this map. So we have gasoline stations with convenience stores. We have convenience stores, small grocery stores, those little mom and pop stores, and supermarkets. And if you look, you're going to be hard pressed to find a supermarket in those areas. And what you do find there is that probably a majority of those people are getting a lot of their food from the gas stations and the convenience stores, and they don't have access to the fruits and vegetables that they need and the healthy selections that a lot of us take for granted. So how do we address this? That's not easy. Brian mentioned going into the communities as well, and we need to pull our resources together. We need to look at farmers markets, food pantries, food banks, and all those issues, and how do we get them to those areas that we know don't have anything. As well as we need to go to the community and we need to ask them what is the best way to get that to you. Is it going to the bus stops and having a farmer's market at a bus stop, or having one of those food trucks now that they have that are the farmer market trucks that can go from community to community and sell those fresh fruits and vegetables. But this is going to take some work to come up with the strategy that works best for our community.
Thank you, Dr. Payton. The next question, just so everyone knows, the next question has been asked of all the panels and will be asked of the panel tomorrow. So this is a common question for all the panelists. And we have asked all 7 of our panelists to answer this question, but we're going to go, instead of starting with Brian this time, as we did with question 1, we're going to start with you, Sarah. Since you're warmed up, you'll be able to just keep going. So question number 7 is, what is the rule or regulation you would eliminate today if you could, and what simple change could it make? How would it impact any of our 3 focus areas, education and life skills, health and safety, and income and stability? Dr. Payton.
Okay, well, my focus is health because that's the arena that I work in the most. And when I look at data from all sorts of outcomes for all sorts of risk factors, I see so much deaths, illnesses that are directly attributed to tobacco. And there is a bill out there in legislation in Ohio that is looking at increasing the price of a pack of cigarettes by $1 per pack, as well as equally increasing other tobacco products as well. And I think this is really an important strategy. If I could wave my magic wand, like Andrea likes to say, I would make this happen because we know what a big impact it would have on the health of our community. If you see some of this data here, 12% reduction in youth smoking rates. And we know that our lifetime smokers, most of them start before they're 18 years of age. And if we can prevent them from starting, and youth in particular are very price sensitive, what an impact that would make on the health in our community. Not to mention, we would prevent over 40,000 smoking-caused deaths and save billions of dollars in Ohio.
Thank you. Sheriff Plummer?
I'd have a permanent injunction against legalizing marijuana. Just kidding. That's going to be another problem for us for health issues. Back to the data problem we have, and me and Commissioner Foley speak about this all the time. We may need to look at the HIPAA laws because it kind of ties our hands on collecting data. Not to eliminate them, but tweak them some. So if we have somebody suffering from mental illness, substance abuse, they're in jail all the time, they have, hepatitis, AIDS, they're a problem for our staff, they're a problem for the community. We can't collect certain pots of data that we need. And we always talk about this, Dan, we've got a certain group of people using all of our resources. So if we can collect all the data on this certain group of people and get them the help they need to get them out of our systems, we'll be money ahead. Not to change the whole law, but it needs change for public safety, I think. If they're going to be a burden on society, not always by choice, they may have to lose some of their liberties, and we need the data to help fix them, because obviously they can't reach out and get themselves fixed. So I think that would help us out, and that's my answer.
Thank you, Sheriff Plummer. Major Johnson?
If I can change one thing, kind of goes back to what Andrea said a little while ago, I would change the way we actually deal with female prostitution offenders. I was in the vice unit for many years. I've probably been involved in close to 5,000 arrests of prostitutes, and I first didn't feel this way. I would arrest a lot of them and put them in jail and not think much more of it. But when you actually look at the female prostitute, we treat her and the male the same way, which really we shouldn't. The female, in my view, should be seen more as a victim. Probably over 95% of the females we ever arrest in the city of Dayton for prostitution or opiate or drug abusers who prostitute to get money for their drugs. And it really is a very sad case to see a person in that state in their life. And I think back to one arrest I made on West 2nd Street where a lady was having sex with a man in a car. And I get her out of the car and she goes, yeah, I had sex for $2. It was like $2.70-something with this man. And, I think what we should do is treat them more as a victim. We've kind of taken steps toward that in Dayton. We did seize a home from a drug dealer here in Dayton, Ohio, and that home was used under the Operation Goodwill program from U.S. Marshal Service. So it was seized, given to a group who actually catered to women called the Oasis House in Dayton. So they catered to women involved in that industry and getting them off the street. But ideally, I would like to see us be able to provide help for women like that without giving them a criminal conviction. So, we arrest them as a police officer, we have to take them to jail. Ideally, it would be nice to see them on the street working and take them to a place to get them help. But we treat both the woman and the man in that crime in the same. I think we should look at more, not, if they did it, but why they're out doing it. And it's tough, because, the women do it for drugs and the men do it for power and because they can. So most of the men that we arrest in Dayton aren't from Dayton. They're from suburbs. They have jobs. They have families. They have cars, and they come here and do this in our city, and they get probation, usually the first several times before they even get jail time. So that's what I would change if I could.
Thank you. Andrea?
Well, I actually have two, although they both have to do with Medicaid restrictions. The first one is the fact that individuals lose their Medicaid eligibility when they are incarcerated, which is understandable as they become the responsibility of the institution, but what it does is it creates a gap of time when they are released from that institution prior to getting the treatment services that they need. This has become particularly problematic for our opiate-addicted populations who could very significantly benefit from receiving the start of medications while they are in jail, truly life-saving medications, because we know once individuals get out of an incarcerated setting, they are much more highly likely and much more at risk for an overdose situation because their tolerance has decreased while they were abstinent. So starting those medications in jail prior to their release could literally save people's lives. The second one is a Medicaid restriction on individuals who are in what's called an Institutions for Mental Diseases facility, which is a facility that has more than 16 beds. Its patient roster is more than 51% with a severe mental illness. The population between the ages of 22 and 64, they cannot get reimbursed for Medicaid for that particular population. That means that is the sole population that goes without Medicaid eligibility for an inpatient service, and completely discriminatory. This has been in place since 1965 when Medicaid was enacted, and at the time there were several large local and state psychiatric facilities housing lots of people, and it was doing so through non-federal public dollars. And so at the time, Congress did not want that to be supplanted with the new Medicaid dollars, and so they put this restriction in place in 1965. 50 years later, it's still in place. And things have changed dramatically since then. One of the unintended consequences then is because the individual's Medicaid is extinguished while they're in the facility, the IMD facility, is that if they do then have to be treated for medical purposes, they have to leave the IMD facility, reinstate their Medicaid, get the medical service, and then go back to the IMD facility, which is just unacceptable. And it continues to exacerbate the myth that mental illnesses are not physical illnesses, and therefore they get inferior Medicaid coverage. So I would change both.
Thanks, Andrea. Jeff?
So public health's perspective on this is really simple and really succinct, and that is if it's all about where the funding goes. So it's not really about a rule or regulation change. If you look at the slide on the screen, the left side, which says causes, those are really the determinants of our health status and their respective contribution to premature death. And so it's very clear that roughly 60% of our health status as individuals and as a population are basically, the primary drivers of that are those social determinants, per se, of health. But when you look at how we fund as a nation prevention in public health in terms of total health expenditures, about 5%. That's probably about 6% for the state of Ohio, as opposed to 95% per se for medical care and treatment and rehabilitation and recovery. That's not to say that that's not important. Every single person in this room and in this community understands the importance of access to affordable quality health care. None of us want to lose that. But if we want to see overall population-level health improvement in this community, then we need to figure out how to better invest in evidence-based upstream prevention methods and strategies that impact those social determinants of health. So that's it.
Thank you, Jeff. Shalon?
Yeah. One of the things that I would, if I had my way, is that I would stop re-victimizing people that have been to prison. If there's been incarcerated for a nonviolent crime, that they will be allowed to come out and find employment, that they will be allowed to come out and find housing, that they will be allowed to come out and even vote. They will be allowed to come out and do the things that we would want them to do to help make our community a better place to live. But yet we find in some instances they come out, they can't find a job, they can't go to school, they can't find proper housing. And so what do? They revert back to doing what they normally are used to doing and go back into the prison system. And so I think that as a community, that it is imperative that we, become advocates for that, because we want our individuals to be healthy. We want our communities to be healthy. But yet and still, when you and I say this because I just spoke with a young man a couple of weeks ago that said that he thinks he's better off being back in prison, and that does not make any sense. And it's because of the fact that he cannot find a job. He even applied for school, and they told him that if he had a felony, that he couldn't even apply for school. I'm like, we're going to have to investigate that one. But I think that we need to really take a look at some of the things that we have in place that really do not allow people to become self-sufficient. Do not allow people to be able to live and have a quality of life that we all want. So I think that that's one of the things. And the other thing, and this is very short, the other thing is I would stop making the intake process so stressful for individuals that are coming through your doors. They have so many barriers in place trying to access resources because of the long, drawn-out intake process. And so I think that those are some of the things that I would like to see in place to make our community a better place.
Thank you, Shalon. Brian?
I want to echo Andrea's 2 points on the Medicaid issues. Those are critical components, not just for our community, but across the state. The other thing I would coordinate on a state level the community health assessment requirement for public health, so it coordinates with the Affordable Care Act and what the hospitals are required to do. I think that there could be some efficiencies with that in order to coordinate those community health assessments in a joint way. So it's on the same time frame, we have the same metrics and more coordination. I think that's something that we could do. And the second thing is Montgomery County specific is streamline the processing of guardianships in our community. In Montgomery County, it is an average of 2 to 4 days longer than surrounding counties to process guardianships. That increases length of stay. It increases the amount of time before somebody can get medications if they need a guardianship, especially if it's a mental behavioral health issue. So it's a quality of care issue, but it's also a length of stay issue. Our hospitals spend somewhere between $500,000 to $750,000 just to process guardianships in Montgomery County. And that doesn't even account for the additional lengths of stay that individuals have in a facility that may not be the right place for them. Once again, going back to making sure people have access to the right care at the right place at the right time for the right cost.
Thanks, Brian. Thank you, panelists, for question number 7. Question number 8 is the last question. This is another question that's being asked of all the panels. And the question is as follows. In summary, based on everything you've heard today, what would you stop, change, or add to what we're doing in the community today? And your answer cannot be funding. Again, based on everything you've heard today, what would you stop, change, or add to what we're doing in the community today? Andrea, lead us off.
Well, I think that this requires some courage on behalf of our funders, but the one thing I would stop doing is I would stop funding programs and services that have not had the ability to be proven to be effective in keeping people healthy. And we do it all the time. We fund programs just because they've been funded year after year after year. And I would cease doing that. And while I know that proving that you have prevented something is challenging, we now have sophisticated scientific research methods that allow you to do just that. And we've also identified that when you do prevention programs that haven't proven to be effective and maybe don't exist in the evidence base, sometimes what research is showing is sometimes they actually have an opposite and harmful effect. And I'll give you a really brief example. Schools, in the goodness of their hearts, really love to bring in people who are in long-term recovery to talk to their young ones about the horrifying stories and lives that they've led because of their substance use disorders. And they think that that will be preventative to young people. What our brain research is now telling us is that young people at that age are wired for risk-taking, and their frontal lobes, which is the last place that gets developed in those teenage years, that is responsible for decision-making and understanding consequences, they don't understand the long-term consequences of that. So it backfires, and actually those young people end up wanting to use more because of the experience they've had in that, what would be like an all-school assembly. I would have, in place of those programs that are not effective, I would have those same funding entities, our Adamus boards, our FCFCs, our human service levies, even our private and public foundations and corporate foundations that provide funding to prevention services, to work together and create that comprehensive, well-balanced community plan, prevention plan that I talked about earlier, to make those funding decisions on where the dollars would be best spent and where we can actually start to see changes in population health, not just at the individual level, but at the population level.
Thank you. Sheriff Plummer?
I think we should really look at our mental illness population and, really devote resources to that. I mean, I get tired of seeing the same people in our jail every day who are arrested for petty theft, threats, trespassing, panhandling, and prostitution. They're released. Sometimes they're arrested twice a day, and they don't need to be there because of the mental illness they're suffering. So we need to take a look at that population, which also goes hand in hand with the substance abuse problem. And I think we could really cut down some of our cost and make a better quality of life for those people. Because what we're doing for them right now, arresting them, processing them, turning them back out, it's a vicious cycle that's not working. So I think we should really focus on that population. We have resources available. Let's see what's working and what's not working and devote some of the resources on programs that aren't working towards that population.
Sheriff Shallon, you go next.
Oh, okay.
What would you stop, change, or add?
One of the things that I would do, and this, and I hope it's okay if I'm going to put this to the audience, is that look at one of these focus areas, and whatever is your passion, to begin to advocate for that, because we don't have all the answers. And we need the community, and we need you guys to help us to understand what it is that we can do better to make sure that this works for the whole community. That's what I challenge you to do today. Just pick one area. It doesn't have to be a month, because it only takes one person in a lot of instances to make a difference. To make a difference for the whole community. So that's something that I would like to do today in terms of making sure that we all are inclusive in this process.
Thank you very much. Major Johns.
I would add two things. I would add more street-level services that I kind of discussed earlier. I just, like last Friday, we were painting over graffiti on East 3rd Street. We had some young folks there from juvenile court, and we had 3 female prostitutes working on 3rd Street. And, I think we need to actually take our services that we have that are in certain locations, actually, and bring them to the street where they're needed the most. I got the honor to go several months back to Milwaukee and view their needle exchange program as we're kind of gearing up for ours there. And they actually, you can call a number in Milwaukee, a phone number, and they will actually come to where you are and bring you a clean needle, and that way to kind of reduce the spread of that disease and HIV and things like that. And in that very same van, you can get naloxone for overdose to save your life. You can get everything a fixed needle exchange site has. That mobile site has it, and I think that was just a great idea on how they take such life-saving vital services and take them to the street where they're needed most. Because if you think that lady on East 3rd Street will actually come into a clinic downtown, it's not going to happen. We had an officer stuck with a needle several weeks ago and making a prostitution arrest, and she was HIV positive. and also had hepatitis. So I mean, it's a big issue. So I definitely add street level services. And the last thing before my time runs out that I would like to add, I know Sheriff Plummer was really already on it, but it is an increase in Vivitrol services here in the city of Dayton. I know he's working through the jail to give that Vivitrol shot when you actually leave jail. A lot of the overdose deaths that we see are folks who leave jail or leave prison and they get out and use heroin again and try to use the same amount they used before they went into jail, and their body can't handle it and they overdose and die. I'm not a doctor. I don't know a whole lot about Vivitrol, besides what I've read and what I've learned from folks, but I think Vivitrol upon leaving the jail is an excellent idea, and to have a Vivitrol shot available at a more reasonable price range for those folks on the street who need it, and a place to get clean, because they have to be clean for like 5 days prior to using Vivitrol, and to provide that and that Vivitrol, because I know it's some folks debate that you're just substituting one drug for another, but if we can at least save their life and get them the help they needed, we'll be a lot better off at the end of the day.
Thank you, Major Johns. Dr. Payton.
So as the epi and me, it's been very nice to hear all of you, or at least most of you, talk about data in all sorts of different ways. I'm one of these weird people that I dream, like what my dream would be to have all your data sets at my beck and call so I could do everything at one time. But really, this data, it's great because there's so much we can do, and I've jotted down some notes from what I've heard everybody. So data sharing, how much more effective can we be with what's going on in our communities if we can easily share the data from the hospitals, from the crime, from the substance abuse, from public health, and put that all together. We have, in addition, evidence-based data. Let's use our data to make our decisions here or to start the process and what strategies we need in our community. And in addition, let's use the data, make sure we set that up at the beginning to evaluate how we're doing. So if it's not working, we can take a step back and readdress what we need to do, as well as what Andrea was saying. Let's put the money into those programs that show the data, that show that we're making progress. With that, let's use evidence-based. Let's look at the data out there that other communities have collected and work with that in our community that have shown to make a difference. And Brian mentioned data too. How do we align all of our community health assessments and our improvement plans so that we're all working from that same database to better align what we're doing to make choices on a community base? So I've been very pleased because everybody has supported my data love here.
Thank you, Dr. Payton. Brian?
I was told there'd be no math, so I'm upset that there's nothing but math. There's a reason why I was a political science major, and most of it was to avoid math. I think for us, it's the transparency on what we're trying to achieve and making sure that there's a central repository on whether we're being effective or not. And I think one of the things that this community has already come up with, so I don't think we need to reinvent the wheel, is the Montgomery County Commissioners had the foresight to put together a group of community advocates to work on the Affordable Care Act Implementation Task Force. So we have a dashboard that all the community, different health partners and individuals are sitting up here on the dais we're part of, and it shows, we're being successful or not being successful in a certain area, or if we're moving the needle and trending in the right direction. I think that's a key component to make sure that everybody has access to that, and that there's a clear set of goals knowing what we're trying to achieve. And we're obsessed with metrics, and we want to make sure we're measuring the right things and making sure that we're doing things to cause a positive outcome in those metrics. And so I think that would be the most positive thing, is to kind of bring that dashboard front and center and say, hey, these are the areas that we're really trying to focus in on, making sure people have access to care, have access to the right resources in the community, and realize that it's just not a healthcare issue or law enforcement issue. There's a whole set of wraparound services that we need to be coordinated in a fashion that's open to everybody in the public in a transparent manner.
Thank you, Brian. You take us home, Jeff. You going to share some data with us?
We're going to share a little bit
better.
data, but I purposefully stayed away from a lot of the data as well, because every time I think I can explain data, then I listen to Dr. Payton, and it's pretty clear I'm not a data specialist. So, hey, it's a humbling experience. Actually, Dr. Payton's invaluable in terms of the role she plays at public health and assisting our initiatives to make this a better community. So from a public health perspective, it's really about reducing the leading causes of preventable deaths and disabilities, reaching out to vulnerable populations, and promoting health equity. We believe those three areas remain the cornerstones for creating a healthier Montgomery County and improving the overall health of our population. If you look at the data, again, which Don Ebron in the back of the room and Dr. Sarah Payton were responsible for developing, in addition to the 2013 FCFC Joint United Way Community Needs Assessment, it's pretty clear that certain areas stand out. My specific copy of this health assessment has untold numbers of little tabs that help me to remember those key focus areas. So it's not really for us about changing or stopping something. It's about continuing to add to our investments as a system of partners in terms of chronic disease prevention, infant mortality reduction, behavioral health, both mental health and substance abuse prevention and treatment, and then tobacco control. We would be a far healthier community if we continue to add to investments to address those issues. If you go on to the next slide then. As many of us have talked about today, it's really about addressing those social determinants of health and improving living conditions of individuals with respect to their physical environment, their social environment, as well as their economic environment. We believe at Public Health that an appropriate framework is the spectrum of prevention, understanding how our strategies as a system of partners align on the health impact pyramid, and then incorporating health in all policies, specifically health impact assessments, to better inform decision-making across all sectors. And so in the 30 seconds or so that are left, as an example, from a tobacco control standpoint, we know that low income and low educational attainment results in higher smoking rates. Well, from a health impact perspective, and the strategies we select, obviously we should be looking, as Dr. Payton indicated, increasing tobacco taxes, implementing tobacco-free workplaces, parks, schools, universities. Anti-tobacco ad campaigns can be very effective in reducing tobacco use. And then as we move up that pyramid, obviously contributing would be clinical care, cessation, and counseling, clinical counseling and cessation medications for tobacco. Public education alone, although it's heartfelt and is well intended, it's not effective long term as a public health strategy alone. For example, if we were to have individuals as community health workers and from public health and other partners engage low-income neighborhoods to recommend residents stop smoking to address and reduce their risk of heart disease and cancers, that message gets lost, because it's overwhelmed by the more urgent concern of violence, drug use, unemployment, and keeping families together. So it's really about a system of partners addressing those social, economic factors that ultimately are the primary drivers of health outcomes and health inequity in this community.
Thank you. So was that good or what? Huh? Sincerely, I want to thank all the panelists. I know it's a lot of work to prepare for these sessions and then to actually sit up here and do it. We truly appreciate your time and your efforts. And we also thank everyone in the audience for coming. Keep in mind, we do want to hear from you, so please take those 3x5 cards, write your questions, your comments, and give them to the folks in the back of the room before you leave. With that, I'd like to ask Tom Kelly to come back to the podium. I think we're almost done.
So I'd like to add my thanks to everyone as well. If you could also join me in thanking Jim for facilitating the group this afternoon. Now, just a couple of housekeeping things. If you did write down some notes, some comments, or some questions that you'd like to turn in, looks like Kimma has a red basket in the back, and I think Rita has one as well. So you can turn those in on the way out, and we'll collect them, and again, we'll feed them into the ongoing process as we're moving through the summer and the fall. Housekeeping things. Remember to get a parking pass if you need one so you can get out of the garage for free. That's very important. As we also said earlier, we are videotaping all of these sessions as well. We started last Thursday with the first session, and we'll continue that through the final session, which is on Thursday evening. The videotape should be available on our website. That information is here. Should be available after about June 1st or so. But the videographer who is in the back will be handling all these and editing them. So you do have all the material that was covered today. Whether it is the comments from the panelists, it is the facilitator asking the questions, and it will include the slides that you've seen that were part of the responses today. So the videos will be complete. I feel like I'm missing something. Oh, if you did not sign in when you arrived, please sign in as you leave, just so we have an idea of how many people have been in attendance for the sessions. I think that's it. So, next session? The next and final session is Thursday, beginning at 3 o'clock. It is not here. It is at the National Composite Center in Kettering.